Welcome back to the Blood Cancers Blitz Roadmap of Acute Lymphoblastic Leukemia Lymphomas. Today we will begin in the lymphoid hemisphere. What is acute lymphoblastic leukemia lymphoma? It is a destructive excess of lymphoblastic lymphocytes. But what does lymphoblastic mean? It refers to lymphocytes that have a precursor or stem cell phenotype. Let's keep in mind that lymphocytes begin in either the bone marrow for B cells and the thymus for T cells. The challenge for yesterday was to consider how many acute lymphoblastic leukemia lymphomas you are aware of. How many did you find? Here's my list from the WHO. Before we dive in, take a deep breath and look for patterns. We'll begin with B cell precursor neoplasms and then consider the T cell precursor neoplasms. If we look at the B cell precursor neoplasms, notice that a lot of them have the word fusion, rearrangement, or diploidy. Thus, after we identify blasts and confirm that they're B cells, we can look for these with a cytogenetics or FISH report, looking for rearrangements, fusions, or ploidy. With those reports, we can identify the lesions as B lymphoblastic leukemia lymphoma with high hyperdiploidy, with hypodiploidy, with amplification of 21, with BCR-ABL fusion, with KMT2A rearrangement, with ETV6 RUNX1 fusion, with TCF3 PBX1 fusion, with IGH IL3 fusion, with TCF3 HLF fusion, or a number of other defined genetic alterations. If our report does not match up with any of these specific categories, the category of B lymphoblastic leukemia lymphoma NOS is available. However, there is another step that we can take. That is send for gene expression profiling. This will help us identify cases of B lymphoblastic leukemia lymphoma with BCR-ABL 1-like features and B lymphoblastic leukemia lymphoma with ETV6 RUNX1-like features. Each of these entities have gene expression profiles that are similar to the named rearranged version, but they lack the rearrangement of that gene. So BALL with BCR-ABL 1-like features and BALL with BCR-ABL 1 fusion have similar gene expression profiles. However, BALL with BCR-ABL 1-like features lacks the BCR-ABL 1 fusion. With these in mind, the top tool for B acute lymphoblastic leukemia lymphoma subtyping I would consider to be FISH and karyotype, because then we can identify the named fusions, rearrangements, or changes in diploidy. For B acute lymphoblastic leukemias, there is a slight difference between the WHO and the ICC. Whereas the WHO has a um, has several defined genetic alterations, the ones we mentioned before, BCR-ABL fusion, and so forth. It has a large category of BALL with other defined genetic alterations. The ICC system specifically defines BALL with a longer list of defined rearrangements, such as with DUX4 rearrangements, with MEF2D rearrangement, with MYC rearrangement, and so forth, before having a larger category or an ending category of BALL with other defined genetic alterations. So basically, ICC defines more genetic alterations than the WHO5 does. However, the majority of these would still be available or detectable with fish or sow genetic studies as they are rearrangements. So that's it for precursor B ALLs. How can it be difficult? Actually, the more difficult portion is confirming the precursor B cells. They typically are expressed TDT 45, CD45 dim, and they can have CD34 expression, but that is variable. Precursor B cells often lack surface immunoglobulin kappa lambda. However, that by itself is not a diagnostic feature because um, other large cell lymphomas also lack surface immunoglobulin. Another key feature of precursor B cells is expression of CD10. However, within the B cell world, within the B cell continent, there are other neoplasms that can express CD10, such as follicular lymphoma and other large B cell lymphomas of germinal center phenotype. So we have to take all these features along with morphology to and integrate them together to convince us that there are precursor B cells. The other slight challenge is confirming excess. For B ALLs, there's no firm cutoff, like there is a 20% cutoff in many AMLs. And normal precursors, called hematogones, are often present in the bone marrow. And there are certain situations in which those normal precursors can be expanded, such as after a bone marrow transplant, ITP, or some other type of marrow insult or regeneration. It is important to keep these situations in mind so that we don't overdiagnose a B acute lymphoblastic leukemia just because there are a few expanded hematogones or B cell precursors. Thankfully, um, from a diagnostic perspective, most cases of B acute lymphoblastic leukemia do not hover around 20% or anything near that. They're usually pretty extensive in the marrow or peripheral blood, often in the 80 to 90% range. Another challenge to dealing with B ALLs is minimal residual disease evaluation. You may notice that the diagnostic subtypes that we defined or described were based on cytogenetics, fish, and ploidy findings. This tells us that the specific immunophenotype may be variable within a specific category of subclassification of diagnoses. So some may have CD20, some may be negative for CD20, some may be positive for CD19, others may be negative for CD19, some may be positive for CD10, some may be negative for CD10, and so forth. It's important to keep track of the specific immunophenotype of the ALL at diagnosis so you can know specifically what to look for when you're considering minimal residual disease. Continuing down the list, we can see variable expression of CD58, CD38, CD81, and CD34 in a number of BALLs. An additional tool to help in the determination of minimal residual disease is clonoSEQ, which is most useful if it is performed at initial diagnosis. Then it gives you a clonal marker to track later on. It's also important to check the history for any sort of monoclonal antibody therapy. So if the patient is treated with an anti-CD20 antibody or anti-CD19 therapy, then normal precursors or minimal residual disease candidates may lack those specific markers. So that's our survey of the precursor B cell neoplasms. Now we turn our attention to the precursor T cell neoplasms. In this case, there are only two choices: T lymphoblastic leukemia, lymphoma NOS, and early T precursor lymphoblastic leukemia lymphoma, or ETP, ALL for short. For T-ALL, after we identify blasts and confirm a T cell phenotype, we check the immunophenotype to rule out ETP-ALL. ETP-ALL is typically negative for CD1A and CD8 and shows loss of CD5. So for T-ALL, the top tool to use would be immunohistochemistry or flow cytometry. T-ALL often presents as a mass, and in those situations, you would use immunohistochemistry. If it presents as in the peripheral blood, then flow cytometry will be the tool to use. Like with precursor B cells, confirming precursor T cells is where things get only slightly more tricky. The precursor um, markers that we would look for are TDT, DIM CD45, CD1A, and CD34. However, within a variety of T-ALLs, the expression of these can be variable. Another immaturity marker that we can look for is CD99, and that also has variable expression and is nonspecific for T cells, as it can be seen in a number of other small round blue cell tumors from the surgical pathology world. T-ALLs can have CD10, however, this expression is variable, and we already mentioned the differential diagnosis with other B-cell lymphomas. Precursor T-ALL is often positive for CD7. However, this is not a specific precursor marker. T-ALLs can also be double positive for CD4 and CD8 in some cases. However, the differential diagnosis for that includes T prolymphocytic leukemia. So that's not completely specific for T-ALL. In addition, confirming excess can theoretically be challenging for T-ALLs. Again, there's no firm cutoff, unlike the 20% we see in many AMLs. And normal precursors are often present in the thymus, and they can be expanded in various situations, such as if there is a thymoma. Furthermore, determining minimal residual disease can present some challenges. With all the variability with markers that you can see in T-ALL, it's important to keep track of the immunophenotype at diagnosis, whether there is the presence or absence of TDT, CD34, CD1A, CD99, CD10, CD7, and CD4 and CD8. T-cell clonality molecular studies can be useful for to compare for future minimal residual disease evaluation. So if we put these two steps together to consider the diagnostic pathway for B-ALL and T-ALL, from a diagnostic perspective, first confirm the precursor phenotype with flow or IHC. If you have B-cell ALL, use cytogenetics and FISH studies for subclassification. And if T-cell, rule out ETP. From a clinical perspective, you want to determine the method of minimal disease measurement and cooperate with clinicians. Describe the immunophenotype in detail and send for clonoSEQ, IGH, or TCR studies as you would discuss with the clinician. Now let's do some cases. Under the microscope, we see an excess of lymphoid appearing blasts. They have scant, deeply blue basophilic cytoplasm, round to irregular nuclei. loose chromatin, invariably visible nucleoli. By flow cytometry, they're dim for CD45, express CD19, CD10, CD20, TDT, CD38, negative for CD58, positive for CD81. On FISH report, we detect a BCR-ABL fusion. There's no other history of previous disease. What would be your diagnosis? B-ALL with BCR-ABL1 fusion. Let's consider another. Again, we see blasts under the microscope. CD45 dim, CD19 positive, 10 positive, 20 variable, TDT positive, 38 positive, negative for 58, and positive for 81. This report shows ETV6 RUNX1 fusion. What is your diagnosis? B-ALL with ETV6 RUNX1 fusion. Let's go again. Flow in this case shows 19, 10, negative for 20, TDT positive, 38 positive, negative for 58, positive for 81. But our FISH report shows no specific rearrangements. However, our karyotype shows only 22 chromosomes with loss of X, 2, 3, 4, and a number of other chromosomes. What's our diagnosis? B-ALL with hypodiploidy. And our karyotype comes to the rescue. One more. This time the flow shows, or the analysis of the flow shows CD45 dim, positive for CD7, positive for CD3, CD5, CD10, CD1A, CD99, and TDT dim. What's your diagnosis? T-ALL. So again, the combined steps for ALL evaluation: diagnostically, confirm the precursor phenotype. For the B cell, use cytogenetics FISH for subclassification. If T cell, rule out ETP. Then from the clinical perspective, determine a method of minimal residual disease measurement and cooperate with the clinicians. Should describe the immunophenotype in detail and discuss other clonality studies that you would use for further evaluation of minimal disease. Congratulations. We have a mental map for B and T ALL. Challenge for tomorrow. How many large B-cell lymphomas are you aware of? How could you organize them? Store your responses in a notebook, digital file, or blog. Bring your answers back tomorrow. And until then, let's blitz.